Hello, it is Miss Page, and this lecture is going to be covering hematologic disorders. Our objectives for this lecture, we are going to differentiate between the functions of erythrocytes, leukocytes, and thrombocytes, list common diagnostic tests for evaluation of blood disorders, and discuss the significance of the results, compare and contrast the various types of anemia in terms of etiology and pathophysiology, clinical manifestations, assessment, diagnostic tests, medical management, nursing interventions, patient teaching, and prognosis. Discuss important issues to cover in patient teaching and home care planning for the patient with pernicious anemia. And compare and contrast the disorders of coagulation, which are thrombocytopenia, hemophilia, and disseminated intravascular coagulation, in terms of etiology and pathophysiology, clinical manifestations, assessment, diagnostic tests, medical management, nursing interventions, patient teaching, and prognosis.
First, we'll do a bit of a review. So when we talk about hematologic disorders, we're going to be talking about the different types of disorders that go with blood cells. So you have your red blood cells or your erythrocytes, your white blood cells or your leukocytes, and then you have your platelets, which are also thrombocytes. Pay attention to your white blood cells, your leukocytes. Those go into further, they're broken down into granulocytes and agranulocytes. And we'll talk about that a little bit farther, or a little bit later in the lecture. Values that you need to know. So your red blood cells, for males, it's going to be 4.7 to 6.1. For females, 4.2 to 5.4. Hemoglobin for males, 14 to 18. Females, 12 to 16. Hematocrit for males, 42 to 52. 37 to 47 for females. Your white blood cell is 5,000 to 10,000, and platelets are 150,000 to 400,000. Those are your normal value ranges. First disorder we'll talk about is anemia, and then we're going to break down anemia further into different types of anemia. So this one's just going to be kind of a basic overview. And you can see on the right hand of the screen, there's a diagram of kind of the different types of anemia that we'll talk about. Not all of them, but most of them. So anemia is a low amount of red blood cells, which causes a decrease in hemoglobin and hematocrit. So you need to remember that hemoglobin attaches to red blood cells, and that's how oxygen gets to the tissues. So if there is a decrease in the amount of hemoglobin and a decrease in the amount of red blood cells, oxygen supply to the tissues and the cells are going to decrease. And then your peripheral circulation is going to compensate that by shunting blood all the way to the vital organs, and that's going to cause hypoxia in other areas of the body. Signs and symptoms of anemia are going to be the general signs and symptoms. You'll have fatigue, shortness of breath, and weakness. If the onset of anemia is sudden, symptoms are going to be more dramatic. So if they're anemic because they're hemorrhaging, then the symptoms are going to be more dramatic. If it's a chronic problem, such as like pernicious anemia, the problem might be found accidentally on a routine lab draw. So they might have like general malaise or heart palpitations, shortness of breath on exertion. So the symptoms aren't going to be as dramatic for chronic anemia. For the causes, so let's say that your patient is anemic because of blood loss. So the blood loss can be maybe from hemorrhaging, from prolonged menstrual periods, maybe GI bleeding. They can also be anemic from bone marrow depression because bone marrow produces red blood cells. They can be anemic from hemolysis, which is the destruction of red blood cells, or they can be anemic from iron deficiency. First, we will talk about hypovolemic anemia or blood loss anemia. So this is the loss of blood, and that decreases the amount of circulating blood and hemoglobin. And remember, hemoglobin carries oxygen on the red blood cells. So in general, that decreases the amount of oxygen that is carried to the body tissues. If there's a blood loss of 1,000 mLs or more, it can have serious complications with it. Causes of hypovolemia can be internal or external hemorrhage, a surgical procedure, GI bleeding, abnormal bleeding with menstrual cycles, trauma, or severe burns. Signs and symptoms are obviously going to be, if it's external bleeding, then you're going to see bleeding, but if it's internal bleeding, you might not see that bleeding. There can be restlessness and irritability, a subtle rise in respirations, weakness, stupor, pale, cool, and moist skin, and that's because all of that blood is being shunted away from the peripheral to the vital organs. A rapid, thready pulse. This can lead to shock if they lose enough blood. Shock is deprivation of oxygen and nutrients to the organs. The greater the amount of blood loss, the more that the heart rate and the blood pressure are going to be affected. In children, they initially might be asymptomatic, and then they will progress to the signs and symptoms of hypovolemia. And also, the patient might have pain, especially if they have internal hemorrhaging, because that bleeding can displace organs, it can distend tissues, and it can compress nerves. Your assessment of hypovolemic anemia. So you'll see the patient will be weak, irritable, restless. They might have thirst, decreased blood pressure, rapid, weak, and thready pulse, rapid respirations, cool, clammy skin with pallor, which is pale, oliguria, mental disorientation, and possibly syncope. Diagnostic tests for hypovolemic anemia. If the blood loss is sudden, it might take 2 to 3 days for the red blood cells to reflect this change. And then after that, the red blood cells, the hemoglobin, and the hematocrit will all be decreased. Your treatment is going to be to stop that blood loss, IV fluid administration, and if that is not helping enough or there's too much blood loss, they might do IV blood administration. Usually the doctor won't order IV blood unless the hemoglobin is less than 7. A good thing to, like a rule of thumb, 1 unit of packed red blood cells should increase the hemoglobin by 1 or raise the hematocrit by 3%. If it is worsening hypovolemic anemia, they might need iron, and that iron will increase the bone marrow production of red blood cells. Your nursing interventions are going to be to monitor blood loss and fluid administration, control bleeding, keep the patient flat and warm. You want to keep them warm because cold causes vasoconstriction, and all of that blood is being shunted to the organs already, so we don't want to constrict that more and cut off blood flow to the peripheral even more. Vitals every 15 minutes. You want to prevent injury, especially if the patient is restless or disoriented, and monitor eyes and nose so you can watch for decreased renal perfusion. Next, we will talk about pernicious anemia. So pernicious anemia results from the body's inability to absorb vitamin B12. So vitamin B12 is necessary for the production of red blood cells. It affects the growth and the maturity of all body cells, and vitamin B12 can also affect the nerves. So if there's not enough vitamin B12, it can lead to the degeneration of nerves and white matter. So If your body doesn't have enough B12, then they're not going to produce red blood cells, and then the red blood cells won't be able to carry the hemoglobin, and the body won't get oxygen. Signs and symptoms, they're going to be the same as the same as anemia, not necessarily hypovolemic, but just in general, so that fatigue, restlessness, weakness. They will also have a smooth, thick, red tongue. They might also have numbness and tingling in the hands and feet, and that goes along with how vitamin B12 affects nerves, and if there's not enough, it can lead to the degeneration of nerves. They might have GI complaints like nausea, vomiting, diarrhea, because vitamin B12 is absorbed in the stomach. And they can also have confusion and memory loss, and that relates to the nerve and white matter degeneration. Assessment, you might see palpitations, nausea, flatulence, constipation, diarrhea, and indigestion. Those are your GI complaints. The tongue will be tender and it might feel like it's burning. It's going to be smooth and red. It's going to be thick, so it might look swollen. Weakness and difficulty swallowing, tingling of the hand and feet. They might also have loss of the sense of body position. Mental disorientation, personality changes, behavior problems, and it can eventually lead to paralysis. Your diagnostic tests are going to be a CBC, so you want to check the hemoglobin, hematocrit, red blood cells. A reticulocyte count, this measures the number of red blood cells in the blood. So basically it indicates if that bone marrow is producing the red blood cells. They might also have a serum folate and iron. A mean corpuscular volume, this measures the size of red blood cells. So red blood cells in pernicious anemia are usually larger than normal. So that's one way that they can diagnose this. Maybe possibly bone marrow aspiration, and then a gastric analysis. So basically this is taking some gastric juices and looking at it and seeing if there's intrinsic factor in it. And if it's absent of intrinsic factor, then that means they have pernicious anemia. And when we watch this video in a few minutes, that will explain the intrinsic factor and stuff. Treatment is going to be that vitamin B12 replacement. It can be oral or injection. Usually at the beginning, it's going to be 1,000 units of vitamin B12 IM daily for 2 weeks. And then it will be weekly until the hematocrit comes back to normal. And then it's going to be monthly for the rest of their lives. So they have to have these vitamin B12 shots or oral replacement. If they don't, you will usually die within 1 to 3 years. They might also need folic acid supplement or an iron replacement, and packed red blood cells if it is severe. Interventions are going to be vital signs every 4 hours. Oral care is important, especially if they have those GI, nausea, vomiting, because you want to make sure that they're eating. And then that takes us to the diet. You want it high in protein, vitamins, and minerals. So make sure they're eating red meat, dairy products, and eggs. Those all have high levels of vitamin B12 in them. These patients are going to be more sensitive to cold, so make sure you're giving them warm blankets and keeping the room warm, preventing chilling. Have them conserve energy because they have that lack of oxygen. So give them small meals, make sure you're planning rest periods with their activity. Monitor bowel movement. This is important if they're getting iron replacement, and we'll talk about that more in iron deficiency. So you want to check the color. And then make sure they know that they have to have a lifetime therapy of vitamin B12.
Pernicious anemia. And you can find written notes on this topic at zerotofinals.com/pernicious anemia or in the hematology section of the Zero to Finals medicine book. Let's jump straight in. Pernicious anemia is a cause of vitamin B12 deficiency anemia. And B12 deficiency can be caused by either insufficient dietary intake of vitamin B12 or pernicious anemia. Let's start with the pathophysiology. The parietal cells in the stomach produce a protein called intrinsic factor. And intrinsic factor is essential for the absorption of vitamin B12 in the ileum. Pernicious anemia is an autoimmune condition where antibodies form against the parietal cells or intrinsic factor. A lack of intrinsic factor prevents the absorption of vitamin B12 and the patient becomes vitamin B12 deficient. Vitamin B12 deficiency can cause a number of neurological symptoms, and these are peripheral neuropathy with numbness or paresthesia, and paresthesia is like pins and needles, a loss of vibration sense or a loss of proprioception, visual changes, and then mood and cognitive changes. A quick Tom tip for your exams: remember testing for vitamin B12 deficiency and pernicious anemia in patients presenting with peripheral neuropathy, particularly with pins and needles. So there's two antibodies, and testing for autoantibodies is used to diagnose pernicious anemia. The first is intrinsic factor antibodies, which is the first line investigation, and the second one is gastric parietal cell antibody, which can also be tested but tends to be less helpful. So what's the management? Well, dietary deficiency can be treated with oral replacement with cyanocobalamin, unless the deficiency is severe. But in pernicious anemia, oral replacement is inadequate because the problem is absorption rather than intake. They can be treated with 1 milligram of intramuscular hydroxycobalamin 3 times weekly for 2 weeks, then every 3 months. And more intense regimes are used where there's neurological symptoms, for example, 1 milligram every other day until the symptoms improve. If there's also folate deficiency, it's important to treat the B12 deficiency first before you correct the folate deficiency. Treating patients with folic acid when they have a B12 deficiency can lead to subacute combined degeneration of the cord and quite significant neurological problems. Thank you for watching this video. If you like the video,
Next anemia we'll talk about is aplastic anemia. This is rare but very serious, and this is when the bone marrow does not produce enough red blood cells for the body to function properly. So we know that bone marrow produces red blood cells, white blood cells, and platelets. So patients with aplastic anemia are usually pancytopenic. And that means that all 3 major blood elements, red blood cells, white blood cells, and platelets, are reduced or absent. Causes of aplastic anemia can be an autoimmune disorder, infections like hepatitis, the Epstein-Barr virus, or HIV, pregnancy, radiation therapy or chemotherapy, or pesticides and arsenic, so chemical causes. Signs and symptoms are going to be your low red blood cells, low white blood cells, and low platelets, which again, that's pancytopenia. And the signs and symptoms are going to directly relate to the suppression of each of those blood elements. So for your red blood cells, fatigue, shortness of breath, dizziness, headache, cool, clammy skin, pale skin, or chest pain. White blood cells, fevers, frequent infections, or flu-like illnesses that linger. And for your low platelets, they might have epistaxis, bleeding gums, petechiae, blood in the stool, or heavy menstrual bleeding. Assessment. So ask them about their history. So have they been exposed to chemicals or drugs? Do they have a family history of it? Assess their ability to carry out their ADLs. Do they get fatigued easily? Check for pallor, signs of infection, bleeding tendencies, dyspnea or tachycardia. Diagnostic tests, CBC and all of the values will be low. There will be a low reticulocyte count and possibly bone marrow aspiration or biopsy, and that will result in low numbers of RBC, WBC, and platelets. Treatment. So first, the cause needs to be identified and then removed or discontinued. So if the bone marrow suppression is coming from anti-neoplastic medications, then maybe they need to change the medication or stop it. Avoid blood transfusions because the body can develop antibodies to tissue antigens. They might need a splenectomy if the spleen is destroying normal platelets. Remember, the spleen gets rid of old platelets and it stores new platelets. So the spleen might be thinking that these normal platelets are, they might see it as foreign, and then it's destroying those platelets, and that can be a cause of the low platelet count, so they might have to have a splenectomy. On page 1488, there is information on splenectomy, like post-op, pre-op, post-op. You guys can read over that. They might have steroids or androgens to stimulate bone marrow, and then it can lead to a bone marrow transplant. Usually this is going to be for patients younger than 45. And again, more information about that is on page 1488. Interventions for this patient: you want to prevent infections. Use strip aseptic techniques for dressing changes or IV care. Avoid IM injection, rectal meds, and rectal temps to prevent skin and mucous membrane injury, because again, they're at a high risk for bleeding because they have those low platelet counts. An air mattress to prevent skin breakdown, and observe for signs of bleeding. Next is iron deficiency anemia. This is when the red blood cells contain less hemoglobin than normal. So remember, iron is needed to form hemoglobin. So a deficiency in iron means that there is a deficiency in hemoglobin. So that is causing the low levels of hemoglobin on the red blood cells. Causes are going to be that excessive iron loss, and this is more so chronic. Maybe a diet low in iron, if there's bleeding from gastric or duodenal ulcers, esophageal varices, diverticulosis, or non-absorption of vitamin B12. This is going to be common in infants, young adults, and pregnant women. Signs and symptoms will be pallor, fatigue, weakness, or short of breath, because remember you have low levels of hemoglobin. Assessment, there will be various GI symptoms, so you'll have glossitis, which is that inflammation and redness of the tongue. Pagophagia, and this is the desire to eat ice, clay, or starches. Weakness, cold extremity, complaints of chest pain. The fingernails will be fragile and shaped like the head of a spoon with a central depression and raised borders. And you can see a picture of that here on the bottom of this slide. That's kind of what their fingernails will look like. Stomatitis and dry, cracked lips are also signs and symptoms. Diagnostic tests, your CBC, red blood cells, hemoglobin, and hematocrit will be decreased, and iron will be low. Treatment, so you would want to administer the iron. There's different ways that iron can be administered. You can do oral, which is ferrous sulfate, IM, which is iron dextrane, or IV, iron sucrose. When you are administering iron, there are some side effects of that. So they can have nausea, diarrhea, constipation, and heartburn. Also, iron will turn their stools dark, so it's important that you educate the patient that their stools will turn dark and to not freak out. Iron can also interfere with the absorption of other medications. So birth control pills, those can increase iron absorption. Cholesterol medicines, antacids, and dairy can decrease iron absorption. So you want to make sure that if they are taking iron, they are taking it at least 2 hours before eating or 2 hours after eating. And if they're taking it orally, that they do not take it with milk. And usually they'll have a CBC about every 3 to 6 months. Interventions, your medication therapy is going to be important. Make sure to plan for rest periods because these patients can get fatigued. Nutritional needs, they need to increase their iron intake. So, dark green vegetables, eggs, liver, shellfish, iron-enriched breads and cereals, those all have iron in them. And again, educate them on that stool color change. The last anemia we'll talk about is sickle cell anemia. So this is when the red blood cells are an abnormal crescent shape and they contain a defective hemoglobin molecule. So you can see up here, this is what a normal red blood cell looks like, and your sickle cell anemia red blood cells are going to look like a sickle shape. Sickle cell red blood cells only last about 10 to 20 days compared to the normal red blood cell that lasts about 120 days. Sickle cell anemia is severe, chronic, and incurable, and it commonly affects African or Eastern Mediterranean heritage. So there is a thing called sickle cell trait, and this is when the person has one gene for sickle cell anemia, or they have one gene for sickle hemoglobin and one gene for normal hemoglobin. So they are just a carrier of sickle cell, so they have the sickle cell trait. They are not going to have any medical problems, and they will normally lead normal lives. The carrier cannot develop sickle cell disease because in order to have sickle cell disease, you have to have the gene from both of your parents. Sickle cell crisis, the main thing here is pain. So if we go back to our angina lectures, we know that ischemia, lack of blood flow, causes pain. So what happens in sickle cell crisis is these sickle cells that are shaped like this, they aggregate or they clump together more easily, and that causes a blood clot. And then that will decrease blood flow distally past this clot, and that's going to cause your pain. So the occlusion, it leads to ischemia, and the ischemia and tissue hypoxia cause the pain. Signs and symptoms of sickle cell anemia. For your newborns, they're going to be asymptomatic for the first 10 to 12 weeks. And then most people with sickle cell anemia are in relatively good health besides that anemia. And they're going to be asymptomatic unless they are having this sickle cell crisis, so this painful episode. Physical and emotional factors can precipitate an attack. So dehydration, infection, overexertion, weather changes, especially cold, alcohol, or smoking. They might have abdominal enlargement with pooling of the blood in the liver, spleen, and other organs. Jaundice can occur, joint and back pain, and edema of extremities. Complications can be multi-system failure, infarctions, hemorrhage, or retinal damage that can lead to blindness. Assessment. You want to know the factors that precipitate a crisis. And then once you find out those factors, you want to help the patient to avoid them. Check for fatigue. Check for pain in the joints, especially in the hands and feet. That's going to be common in your sickle cell patients. They might have abdominal pain with swelling, hypoxia with rapid respirations, deep gnawing and a throbbing pain. That's how they describe the pain that they're having when they're having a sickle cell crisis. Deep gnawing and throbbing. There is a syndrome with sickle cell called acute chest syndrome. This results from the sickling in the blood vessels of the lungs that prevents oxygen entering the lungs. So chest pain, fever, shortness of breath, increased respirations, and cough will be seen with that. Diagnostic tests. So there is a thing called electrophoresis of hemoglobin. Basically, this is going to detect if the hemoglobin is a sickle cell. Their hemoglobin and hematocrit will be low. Their white blood cell count will be increased if the sickle cell crisis is associated with an infection. Skeletal x-rays will show bone deformity and flattening. Treatment is going to be symptomatic. Hydration, antibiotics for infections, NSAIDs for pain. In severe cases, they may need bone marrow transplant, folic acid supplements, hydroxyurea. This is going to help prevent anemia, and that will in turn help prevent acute episodes of pain. And then also, kind of a last resort is going to be your hematopoietic stem cell transplantation. The big thing with your sickle cell patients is when they are having a sickle cell crisis, they are in severe pain. So NSAIDs might not work. You might have to up it to some opioids. Interventions are going to be hydration and analgesia during crisis. Dilution of the blood, that is going to increase the amount of fluid, and that prevents sickling. So they might get IV fluids. Monitor fever and infection. You want to avoid high altitudes, avoid dehydration, extreme temperatures, iced liquids, alcohol, and vigorous exercise. They should be educated to remain current on vaccinations so that it can prevent infection, which can cause that sickle cell crisis. Range of motion exercises, protecting joints, and administering pain medications at set intervals are also some nursing interventions. Now we will talk about Polycythemia vera. So this is hyperplasia or overgrowth of the bone marrow. So this is going to lead to the overproduction of erythrocytes, granulocytes, basophils, and platelets. So all of those, white blood cell, red blood cell, and platelets. This leads to increased viscosity and volume of the blood. So it increases the thickness of the blood and also increases the volume, the amount of blood. This can develop gradually and is usually chronic. They are going to have congestion of the tissues and the organs because they have an increase of volume of the blood and an increase in the viscosity of the blood. So a sluggish circulatory process is going to result in excessive clotting or hypercoagulopathy, and it's going to predispose this patient to infarctions. Signs and symptoms: increased red blood cells. The blood will be thicker than normal. They are going to have a higher incidence of blood clots, so DVTs, PEs, MIs, and stroke. They might have esophageal varices, epistaxis, GI bleeding, and petechiae. This is from venous distension and the platelet dysfunction. They might also see hepatomegaly and splenomegaly, and that's the organ engorgement. Assessment: your patient with Polycythemia vera will be sensitive to hot and cold. You might see pruritus, and that's the itchiness of the skin, and that's going to be related to the increase in basophils, which releases histamine, so that causes the skin to itch. Might see eczema and redness of the skin. Also headache, vertigo, tinnitus, blurred vision, and painful burning of the hands and feet. Diagnostic tests. You will see an increase in hemoglobin, hematocrit, red blood cells, white blood cells, and platelets. You'll also see an increase in the histamine levels, increase in alkaline phosphate and uric acid, and their basal metabolic rate, their BMR, is going to be increased. The treatment of polycythemia vera is the removal of the blood. So they will go and get some phlebotomy to remove around 500 to 2,000 mLs of blood, and that's going to be continually removed until the hematocrit is maintained at 45 to 48%. Then it will be repeated if the hematocrit rises above 50%. They might also be on myelosuppressive agents, so bone marrow suppression, and you can see bisulfan, hydroxyurea, and melphalan, because those will decrease the bone marrow. Interventions. So this disease is not preventable, but you want to avoid fluid overload, which can further complicate circulatory congestion. You want to avoid dehydration because that's going to cause blood to become more thick and viscous. You want to assess nutritional status. They need to increase their intake because that basal metabolic rate is increased. They might also have GI symptoms, so that can affect their nutritional intake as well. And activity should decrease the risk of thrombus formation. Next is agranulocytosis. So if we look over here at this chart, we have different types of white blood cells, and earlier I said they split to granulocytes and agranulocytes. So agranulocytosis is going to be a severe reduction in the number of granulocytes, which are a type of white blood cell. So the white blood cell count is going to be extremely low, which is known as leukopenia, and the neutrophil count will be low, which a neutrophil is a type of granulocyte. Causes could be an adverse medication reaction or toxicity. Some medications that are common to cause this are penicillin, captopril, and ranitidine. Chemotherapy, radiation, or a neoplastic disease can cause agranulocytosis, and also viral and bacterial infections. Signs and symptoms are going to be fever, chills, headache, fatigue. They can have ulcerations of the mouth, nose, pharynx, vagina, and rectum, so the mucous membranes will have ulcerations. And pneumonia and UTIs can occur in later stages. And all of these signs and symptoms are going to be related to that decrease in white blood cell count, so their immune system is low. Your assessment, they'll have fever, fatigue, and prostration, which prostration is extreme physical weakness, kind of to the point where they just collapse. You might also hear crackles and bronchi. Diagnostic tests. Leukocytes with a neutrophil diff are going to be low because this is a low amount of neutrophils. And a bone marrow study will show depression of activity. Treatment is going to be blood cultures to find out what infection, if they have an infection, and how to treat that. Wound cultures from the ulcers, so those can be treated appropriately. Packed red blood cells, and they will be on neutropenic precautions. Interventions. Monitor for early signs of infection. Restrict visitors. Avoid fresh flowers and plants. Make sure you're using proper hand hygiene and universal precautions. High protein, high vitamin, high calorie foods. Avoid raw foods. Increase fluid intake. Meticulous oral hygiene, because that can cause infections if it's not properly cleaned, and avoid crowds and people with infectious diseases. Thrombocytopenia, so if we remember, thrombocytes are also known as platelets. So thrombocytopenia is going to be a deficiency in the number of platelets. Usually they will have a count of less than 150,000. And remember, normal platelet count is 150,000 to 400,000. So these patients are going to have less than 150,000. A common cause is going to be thrombocytopenic purpura. So basically, the platelets become coated with antibodies. And these platelets function normally, but when they get to the spleen, they are recognized as foreign and they get destroyed. So normal platelets last about 8 to 10 days, but with thrombocytopenic purpura, these platelets only last about 1 to 3 days. It can also be caused from viral infections, medications, and autoimmune diseases. Signs and symptoms, you will see petechiae and ecchymosis on the skin because your platelets are what causes clotting to happen. So if you don't have enough platelets, then your body will not clot. Your blood will not clot. So you're going to see petechiae, which are these pinpoint red dots on the skin. And then ecchymosis is this large amount of bleeding under the skin. Assessment, you want to see have they had a recent viral infection that could cause this. Observe for the petechiae and ecchymosis. Check for epistaxis and gingival bleeding. Check for signs of increased intracranial pressure because they can have a cerebral hemorrhage because, again, they're not clotting fast enough. And then watch for signs of a GI bleed, so vomiting blood or blood in the stool. Diagnostic tests. A platelet count. Check the bleeding time, and then a bone marrow analysis. And the bone marrow analysis will show immature platelets. Treatment for thrombocytopenia. If it is an autoimmune problem, they will receive corticosteroids. If necessary, they will receive packed red blood cells or platelet transfusions, or they might receive IV immunoglobulin. Interventions are going to be monitoring that platelet count and bleeding time. Check for bleeding in the urine, stool, or emesis. Avoid trauma or infection. Gentle handling of these patients. Monitor for transfusion reactions if they're receiving IV blood. High fiber diet, that's going to prevent constipation. Educate them to use a soft toothbrush and blow their nose gently. And if it is severe, they could possibly lead to a splenectomy. Next, we'll talk about hemophilia. So this is hereditary. It generally affects males, and the females are going to be the carriers. Basically, what hemophilia is, it is the absence of a certain blood clotting factor which prolongs the bleeding time. So there's hemophilia A and hemophilia B. With A, the blood clotting factor 8 is absent. That's going to be your more common one. And with hemophilia B, factor 9 is absent. Signs and symptoms of hemophilia are going to be severe bleeding from minor injuries, small cuts that can prove to be fatal, blood loss from simple dental procedures that are significant. The blood loss is significant. And hemarthrosis, which is bleeding into the joint space. This is the hallmark sign of the severeness of the disease. So, knee, ankle, elbows, shoulders, and hips. And the hemarthrosis will be combined with pain, edema, erythema, and fever. Assessment, so you will see ecchymosis and hemorrhaging from the slightest trauma, pain with joint movement, and blood in the subcutaneous tissues, the urine, and the stool. Diagnostic tests. So factor 8 and or 9 will be absent or deficient. So it just depends on if they have A or B. Platelets, PT, and INR are normal, but the PTT is prolonged. So that's important to remember. Just the PTT in hemophilia will be prolonged. All platelets, PT, and INR will be normal. Treatments will be transfusions and administration of factor 8 or 9. So there's different kinds of treatments, really 3 that we'll talk about. So the first one is cryoprecipitate, which is factor 8. This is used less because it has a risk of viral disease transmission, because this is directly pulled from donated blood, like when people go to the American Red Cross and donate blood, that's where they get this factor 8 from. So there is a risk of viral disease transmission, such as HIV or AIDS, and this needs to be stored at low temperature, so it's not very good for home use. Human-derived factor 8 is going to be used more often than the cryoprecipitate. It is taken from blood donors as well, and it's going to be treated to inactivate any kind of viral transmission, so the HIV or AIDS. But the one that is most often used is going to be your recombinant factor 8. This is made in the lab, so there is no viral transmission risk. It costs little, so low cost, and there is an unlimited supply. Interventions are going to be controlling hemorrhages by applying pressure and cold to the site. Pain management. Do not give hemophilia patients aspirin, and also educate them on not taking aspirin or NSAIDs. Monitor your eyes and nose, avoid injury, use a soft toothbrush, and gentle movement of the joints, because remember you have that bleeding in the joints with hemophilia. Von Willebrand's disease. This is abnormally slow coagulation of the blood and spontaneous episodes of GI bleeding, epistaxis, and gingival bleeding. This is caused by a deficiency of von Willebrand's factor, which is critical for platelet adhesion. They also have a low factor 8. There are different types of von Willebrand's disease. So type 1 is lower levels of von Willebrand, which is more so quantitative. Type 2 is they have enough levels of von Willebrand, but they all have an abnormality. So this is more qualitative. And then your type 3 is going to be your total deficiency. Treatment is going to be desmopressin. This is the synthetic form of vasopressin, which is an antidiuretic hormone. Basically what this does is it increases the von Willebrand. And administration of plasma concentrates with von Willebrand factor or factor 8 can also be a treatment for this. Finally, we will talk about disseminated intravascular coagulation, or DIC. So this has 2 factors to it. So in general, it's the overstimulation of clotting and the anti-clotting processes. So there is widespread clotting or thrombosis that occurs, and that leads to damaging of the organs. And then this widespread clotting is going to lead to the depletion of clotting factors, which leads to abnormal bleeding. So they basically have clotting and bleeding that can occur at the same time. Causes are going to be, they have a lot to do with pregnancy. So abruptio placenta can be a cause, death of a fetus and delayed delivery of that fetus, and preeclampsia. Signs and symptoms: bleeding in the mucous membranes, venipuncture or surgical sites, or GI and urinary tracts. Also dyspnea, hemoptysis, diaphoresis with cold mottled digits. So it's kind of symptoms of bleeding and symptoms of clotting at the same time. Assessment, you'll find bone and joint pain, changes in vision, purpura on the chest and abdomen. That reflects the fibrin deposits in the capillaries. Usually this is going to be the first sign of your DIC, and you can see here's a picture of that purpura on the chest and abdomen. Might also see petechiae, abdominal tenderness, and in worst cases, GI bleeding, hematuria, pulmonary edema, pulmonary embolism, hypotension, tachycardia, absence of peripheral pulses if there's a clot, restlessness, confusion, seizures, and coma. Diagnostic tests for DIC. They will have a prolonged PT and PTT time. They will have a low platelet count, a deficiency in fibrinogen, a deficiency in factors 5, 7, 8, 10, and 11, and the D-dimer will also be elevated. Treatment for DIC, so platelet transfusion or a factor replacement therapy, possibly heparin therapy if they are not having significant bleeding, because heparin prevents further clots, packed red blood cells, or fresh frozen plasma. Interventions, you want to monitor hematocrit and hemoglobin, assess for signs of bleeding, especially on the skin and the GI tract, monitor level of consciousness and vital signs, avoid needle sticks or IM injections, apply pressure to bleeding sites, prevent injury, pad the side rails of the bed, use foam cotton swabs for mouth care, and avoid contact sports, blowing the nose, razor blades, and a hard toothbrush.
Wrapping up this lecture, our study tips, we should be able to differentiate between the functions of erythrocytes, leukocytes, and thrombocytes, list common diagnostic tests for evaluation of blood disorders, and discuss the significance of the results, compare and contrast the various types of anemia in terms of etiology and pathophysiology, clinical manifestations, assessment, diagnostic tests, medical management, nursing interventions, patient teaching, and prognosis, discuss important issues to cover in patient teaching and home care planning for the patient with pernicious anemia, and compare and contrast the disorders of coagulation, including thrombocytopenia, hemophilia, and disseminated intravascular coagulation, in terms of etiology and pathophysiology, clinical manifestations, assessment, diagnostic tests, medical management, nursing interventions, patient teaching, and prognosis.